So hi everyone, today we are going to cover paraneoplastic syndromes. And basically these are a group of clinical disorders associated with malignant disease. They're not directly related to the physical effects of the primary or metastatic tumor, but they may be due to tumor production of substances causing distant symptoms, similar to multiple endocrine neoplasia type 1 and type 2. So basically, there's a depletion of normal substances, and it's the host's response to a tumor. So we need to treat um, the disappearance of the syndrome, but it may not predictably resolve it with treatment unless we treat the tumor, unless it's metastatic. If that makes sense. So we're going to look at a few of these because we can break them down. I'd like to break them down, the paraneoplastic syndromes, according to their body system. So for instance, musculoskeletal and cutaneous, we have dermatomyositis. It's a progressive proximal muscle disease. It presents with Groton's papules and a heliotropic rash, not unlike systemic lupus erythematosus. You'll find people with dermatomyositis that have adenocarcinoma, particularly ovarian adenocarcinoma. So if you see somebody coming in with, proximal muscle weakness and Groton's papules and a heliotropic rash, you first, on your differential diagnosis, could be adenocarcinoma of the ovary. Acanthosis nigrans is where you have hyperpigmented velvety plaques in the axilla and around the neck, not unlike Graves' disease and some of your either pituitary or adrenal diseases. Usually acanthosis nigrans that develops can be due to gastric adenocarcinoma and other visceral malignancies. The sign of Lesser Trele is a sudden onset of multiple seborrheic keratosis. So basically, they develop really quickly all over the body, on the back and the chest. Um, it's not over a long period of time. The seborrheic keratoses is usually a sign of gastrointestinal adenocarcinoma and again other visceral malignancies. Your hypertrophic osteoarthropy. Arthropy is a abnormal proliferation of skin and bone at distal extremities where you have clubbing, arthralgia, joint effusions, periostosis of the tubular bones. This could be from adenocarcinoma of the lung. Again, a differential diagnosis to be added. Now, endocrine, we have hypercalcemia. Okay, hypercalcemia usually is indicated with an elevation of the parathyroid hormone releasing protein. So it's not from the parathyroid hormone, it's a different exogenous or an accessory to the tumor that's producing hypercalcemia, especially seen in squamous cell carcinoma of the lung, the head, the neck. The renal, the bladder, the breast, and ovarian carcinomas will uh, cause a parathyroid hormone related protein. So that would be first on a differential. It can also cause an increase in 125 dihydroxy vitamin D, which is another long-term chemistry term for calcitriol, which is vitamin D3. And this could be a sign of lymphoma. Cushing syndrome, the syndrome itself, not the disease, usually shows an increase in ACTH, adrenocorticotropin hormone, and your hyponatremia that's found in your symptom of inappropriate antidiuretic hormone uh, is typically found in small cell lung cancer. So you can get Cushing syndrome, you can get an increase in ACTH, and you can get an increase in your SIADH in small cell lung cancer. And I think the reason it's hyponatremia is because when the antidiuretic releasing hormone decides to produce from the pituitary the antidiuretic hormone, then what's going to happen if there's too much antidiuretic hormone, the patient is going to retain water due to a dilutional hypervolemia, causing a dilutional hyponatremia. Just go over a few more and we'll look at the table. Hematologically, we have quite a bit. Polycythemia, you'll see poly, many. Cycellthemia, increase in erythropoietin, which is made by the hematopoietic system, which actually has a tendency to drop in people with severe renal disease, as does vitamin D3. A paraneoplastic rise to high hematocrit levels. You'll see these in diseases such as pheochromocytoma, renal cell carcinoma, hemangioblastomas, and leiomyomas. Pure red cell aplasia is anemia due to low reticulocytes. And reticulocytes are made in the bone marrow. If the bone marrow is not working, we're not going to get reticulocytes. We have cyclic aplasia too, where children will get these peaks and troughs of anemia, and then their body will remake the reticulocytes, and then they'll go into anemia again. It's cyclical. Good syndrome is hypogammaglobulinemia, and you'll find, you know, that coming from a thymoma. And interestingly enough, they've implicated certain diseases directly with the thymus. Trousseau syndrome is migratory superficial thrombophlebitis. Not Trousseau sign, not to be confused with Trousseau sign, which is a sign of hypocalcemia. So when the brachial artery is constricted, the hand twitches, or Shavastic sign, when you brush the cheek, the face twitches. That's a sign of hypocalcemia. Trousseau syndrome is actually migratory thrombophlebitis. You can develop a clot in one leg or another leg or in your arm. Actually, the physician Trousseau discovered this and actually died from this because it happened to him. And that's from Dr. John Barone, who related that to us. Non-bacterial thrombotic endocarditis, the deposition of sterile platelet thrombi on heart valves. You'll see that with systemic lupus erythematosus. It's not necessarily a cancer, but you'll see it in adenocarcinomas and particularly pancreatic, which is interesting. In neuromuscular, the anti-NMDA receptor encephalitis, you'll see psychiatric disturbances, memory deficits, seizures, dyskinesias, autonomic instability, and language dysfunction. This can happen in an ovarian teratoma. Okay, so this is all neurological and neuromuscular. Opsoclonus, myoclonus ataxia syndrome, with the dancing eyes and dancing feet. This is usually seen in neuroblastomas in children and small cell lung cancer in adults, which is interesting because we also see the Cushing syndrome as well as hyponatremia, the symptom of inappropriate antidiuretic hormone. So that's interesting. We can have paraneoplastic cerebellar degeneration, where you have antibodies against the antigens in Purkinje cells, which you can also see in small cell lung cancer. We call that anti-HU, HU. gynecological and breast cancers, Y-O, and Hodgkin's lymphoma, anti-TR. So there is cerebellar degeneration in these. The paraneoplastic encephalomyelitis can be found in antibodies against HU in neurons, which we can see in also small cell lung cancer that perhaps metastasize to the brain. Lambert-Eaton myasthenia gravis is interesting because these are antibodies against presynaptic PQ type calcium channels at the neuromuscular junction, also seen in small cell lung cancer. So small cell lung cancer's got a lot of symptoms. It's got Lambert-Eaton. It's got the paraneoplastic cerebellar degeneration with anti-HU. We have or hyponatremia from SIADH. And so, yeah, the squamous cell only carries the parathyroid releasing protein. So small cell lung cancer seems to be one that embodies most of the signs and symptoms of paraneoplastic syndrome, which is kind of interesting. So let's take a look at symptom of inappropriate antidiuretic hormone, or SIADH. The clinical presentation usually shows gait disturbance, falls, headaches, nausea, fatigue, cramps, anorexia, confusion, lethargy, seizures, and coma. That's because vasopressin, which is released from the posterior pituitary, is released to keep water in our body, right? So if vasopressin is consistently being released from the posterior pituitary into the bloodstream to keep water in our body, the kidneys can't excrete free water, and the kidneys can't, you know, they can't, they have trouble concentrating as well. So we get a mild hyponatremia, right? Because your sodium levels are 135 to 145. So if we're right at 134, you know, it's not really noticeable. Moderate is 125 to 129. Severe hyponatremia is less than 125 milliequivalents per liter, and you'll have increased urine osmolality, which makes sense because if all your free water is being retained in your body, then your urine is only going to excrete a higher concentration. In small cell lung cancer, mesothelioma, bladder, endometrial, prostate, oropharynx, thymomas, lymphomas, breast, GI, adrenal. I mean, this just covers almost all the associated cancers. You want to restrict the fluids, encourage enough salt and protein. Demeclocycline and convipatin and tolvapatin will help in relieving some of that excess water so that the body can eliminate it. Hypercalcemia will cause an altered mental status, weakness, ataxia, lethargy, hypertonia. Renal failure, hypertension, and bradycardia. Mild is between 10 and 11.9, because typically your calcium levels are like 8 to 10. Moderate, and then you see severe. You can get hypercalcemia in breast cancer, multiple myeloma, renal cell cancer, non-small cell lung cancer, lymphoma, ovarian, and endometrial. Lots of cancers. Saline diuretics, pamidrone, zoldronate, steroids, and calcitonin to put calcium back in. Okay. So these are kind of interesting. Your Cushing's syndrome with muscle weakness, peripheral edema, hypertension, weight gain, centripetal fat distribution. These are all syndromes, not necessarily Cushing's disease. Cushing's disease is usually from a pituitary adenoma. Syndromes can come from anywhere. Small cell lung cancer, bronchial carcinoid tumors, such as the MEN 1 and 2 thymomas, uh, GI tumors, ovarian and pancreas, and they tell you how to treat it. Uh, so, you know, Metiraprone, etomidate, mifepristone, these are basically trying to prevent the symptoms. We're treating symptoms at this point with a lot of these. And doesn't mean that we're getting rid of the cancer. We're just basically treating the symptoms. To eradicate the symptoms, you have to eradicate the cancer. Hypoglycemia, and everyone knows the symptoms of hypoglycemia, right? Hunger, weakness, fatigue, can be caused by mesothelioma, sarcomas of the GI and the lung. So it could be a non-islet cell tumor, low glucose, low insulin, low C-peptide. C-peptide and insulin go together. Insulinomas, low glucose, elevated insulin, and elevated C-peptide can cause hypoglycemia. Eosinophilia, clinical features are usually dyspnea and wheezing. And hypereosinophilia is usually, they give you the values here. But associated cancers, Hodgkin's lymphoma, non-Hodgkin's lymphoma, chronic myelogenous leukemia, acute lymphocytic leukemia, lung cancer, GI, thyroid, renal, and breast. Steroids and prednisone is the only treatment for that. Granulocytosis is when your bones are making too many granulocytes, can be asymptomatic. You can have an elevated neutrophil count. You can have an elevated LAP, and they don't really suggest any particular treatment, but you can see it comes from a lot of cancers as well. Okay. So if we take a look at disorders of discoloration and deposition, we kind of looked at some of these. Acanthosis nigrans is associated with gastric adenocarcinoma. Tripe palm, hyperpigmented valvity, thickened palms with hyperkeratotic ridges is gastric and lung. Generalized melanosis, diffuse gray-brown pigmentation, can be from melanoma, adrenocorticotropic hormone producing tumors, and pachydermoperiostosia is thickening of the skin, lips, lids, scalp, and excessive clumping, which is lung cancer. Amyloidosis is very common in a lot of your multiple myelomas, Waldenstrom macroglobulinemia. You get macroglossia, similar to profound anemia, iron deficiency, superficial yellow and waxy pink elevated nodules on the skin, almost like hyperlipidemia. Usually there'll be an M spike, monoclonal M spike. This is what is acanthosis nigrans, and the tripe palms look like. I think the tripe is where they're getting it from beef tripe, which is intestine. It's kind of the thick rugae. The cutaneous manifestations of cancer may proceed with concurrent or discovery of underlying malignancy. A true paraneoplastic process satisfies two criteria: a strong association of dermatosis with malignancy and its parallel course. So while it can be a differential diagnosis, it can't really stand on its own without other significant identifiers that it could be a cancer. So these are just some other papulosquamous eruptions that you'll see in different types of cancers. Paget's disease, you'll see erythematosus keratotic patch over the genital areas. Uh, Basic disease, symmetrical psoriasis form, acral hyperkeratosis. This is very interesting. A lot of these diseases you really don't see here, but I would uh, look at the necrolytic migratory erythema, which are macules and papules progressing to epidermal necrolysis, and you see these in glucagonomas, where too much glucagon is being produced. And so here you see some paraneoplastic syndromes. This is your adenocarcinoma syndrome, seborrheic keratosis that multiplies. So in membranous nephropathy of the kidney, renal manifestations may be a sign of lung, colon, or stomach cancer. So proteinuria can be a symptom of hypertension and macroscopic hematuria. Immune complexes can play a role. Minimal change can be seen in Hodgkin's and pancreatic cancer as well as mesothelioma. Focal segmental glomerular sclerosis can be seen in chronic lymphocytic leukemia, acute myelogenous leukemia, and T-cell lymphomas. This is very bad. Focal segmental glomerular sclerosis. This is phenomenally bad. It goes very quickly. They have to be in dialysis right away. The membrane proliferative glomerular nephritis is also seen in chronic lymphocytic leukemia, Burkitt's, hairy cell, and melanoma. Neutrophils, dermatoses, or sweet syndrome, or pyoderm gangreosum. The malignancy is in multiple myeloma, small cell cancer, mycosis fungoides, which is a type of leukemia. Sweet syndrome, erythematosis, it's a painful, juicy cutaneous papules on face and extremities. You can see it in acute myelogenous leukemia. These are usually hematological malignancies, and they respond to steroids. Of course, steroids have its own sequelae of problems when you have to give too many of them. So, necrotizing necrolysis. There's your necrolysis. So in vasculitis, you see that in non-small cell lung cancer, as well as small cell lung cancer of the esophagus, prostate, and hematological malignancies. Thrombocytopenia purpura, decimated intravascular coagulation, vascular injury, and vasculitis. Multifocal migratory thrombophlebitis in less than 50 years or under. You think of GI, lung, prostate, and ovarian. Mondor disease, cord-like thrombophlebitis of the anterior chest is seen in breast cancer. Some of these I've never heard of. Very interesting. Every country has a predominance for certain different types of cancer. Bullous disorders. Paraneoplastic pemphigus is most frequently seen in B-cell lymphoproliferative orders, including lymphomas, CLL, Castleman disease, thymoma, Waldenstrom, macroglobulinemia, and spindle cell. Oral stomatitis and erosive skin lesions. Internal organ involvement is common, with 30% having respiratory failure. Severe mucosal involvement and pathology is reminiscent of erythema multiforme, which is a hallmark of most paraneoplastic pemphigus. Treat with steroids, cyclosporin, and myclophenate. And just some of the diseases in the oral pharynx. Pemphigus vulgaris is from mouth to feet. it encompasses everything because as opposed to bullous pemphigoid, which is a little bit different, it doesn't include ulcers in the mouth. So vascular diseases like dermatomyositis, the heliotropic rash of periorbital skin, you have the Schall sign, the V-neck erythema, and Groton's proximal muscle weakness are associated with mostly women of reproductive organs, such as breast, and lung cancer. Frequently, the onset is with 1 year of diagnosis. There you go, dermatomyositis. So this just kind of goes into some of the different cancers. AD is autosomal dominant, you see. Peutz-Jeghers. So Muir-Torre syndrome, subcutaneous or sebaceous gland neoplasm. Malignancy goes to the colon and lymphomas. It's autosomal dominant. Cowden disease. Description, cobblestone tongue and fibromas. You see it in malignancies of the thyroid, breast, endometrial, and renal cell. Gardner syndrome, epidermal and sebaceous cysts, desmoids, and lipomas. You see this in adenocarcinoma, bowel and thyroid, also autosomal dominant. Peutz-Jeghers. These are polyps of the GI and pigmentation of the face and lips. You see these in adenocarcinoma of the gastrointestinal tract as well as pancreatic cancer, again, autosomal dominant. Neurofibromatosis type 1, you see cafe au lait spots and neurofibromas, as well as they may have a malignant pheochromocytoma. And this is autosomal dominant. Tuberous sclerosis. You get angiofibromas, pigmented macules, and adenomas. It has a neurological malignancy, and it is also autosomal dominant. Von Hippel-Lindau, you get skin ecchymoses, retinal malformations, papilledema. You see this in renal cell carcinoma and pheochromocytomas. Also hereditary autosomal dominant. Sturge-Weber, you get the port wine stains and cranial nerve 5 distribution. It's a rare neurological malignancy. You have a somatic mutation in the fibronectin gene. So cranial nerve 5, right? You have your olfactory nerve, your optic nerve, your oculomotor nerve, cranial nerve 4, and you have your facial nerve. So when you're taking a look at your at your nerves in general, you want to think about what types of symptoms the patient would find, or what types of symptoms you'd find on the patient if one of the nerves were damaged. So in cranial nerve 5 syndrome, the trigeminal, it spreads a lot through the face, right? And as well does cranial nerve 7. So the what do you call it? The trochlear nerve, cranial nerve 4, you know, it also controls the superior oblique muscles, which helps move the eye down and inward. So if you start to see focal deficits in the trigeminal nerve, it can be considered, you know, in addition to other malignancy markers, you know, part of a differential diagnosis of Sturge-Weber with the port wine stain. Ataxia telangiectasia, you get lymphomas and leukemias. It's autosomal recessive. Bloom syndrome causes photosensitivity, telangiectasias, butterfly erythema of the face similar to lupus. Telangiectasias are like the tiny little capillaries that are under your skin. You can see them really well. Bloom syndrome can cause leukemias and lymphomas. It's autosomal recessive. Chidiac Higashi is recurrent pyoderma with partial albinism because they can't fight infection. It can also cause lymphomas. And Werner syndrome is a can has scleroderma like premature aging and leg ulcers and short stature. Sarcomas, they're prone to sarcomas and meningiomas. And these are some miscellaneous lesions. I said mycosis fungoides is associated with leukemia. Neurological manifestations, this just gives you the percent of paraneoplastic percentage of neurological manifestations. You notice as you get more into the skin, it's neurological is not as paraneoplastic. So how do we approach this? Take a complete history and physical and neurological examination, do an MRI with and without contrast, monitor with therapy, identify where the tumor is. If you need to take cerebral spinal fluid, there has to be an indicating incentive for that or an inciting event to cause that. Tumor ablation is the most effective way of getting rid of any paraneoplastic syndrome. And of course, if we can't, or if we need to do both, immunosuppression and plasma exchange can help, especially with certain aplasias. Well, that's more bone marrow, but for instance, like polycythemia vera. So this kind of goes into different aspects of encephalitis-associated paraneoplasms. 25 patients with anti-WHO syndrome and small cell have autonomic dysfunction, usually associated with small cell lung cancer. This also can occur in patients with myasthenia gravis. GI dysmotility is a core complaint, along with orthostatic hypotension, hypoventilation, sleep apnea, and cardiac dysrhythmias. But we cannot reverse some of these if they've already progressed. Cerebral degeneration can be seen with lymphocytic pleocytosis and mild elevation of protein and oligoclonal bands. If breast cancer, ovarian cancer, and Hodgkin's disease have metastasized to the brain. Antibody may be negative, but may occur in conjunction with Lambert-Eaton, and these are associated with small cell lung cancer. I tell you, small cells everywhere. It does everything. Everything bad, small cell. Visual loss, you can see it also in small cell, non-small cell, and breast cancer with melanomas and adenocarcinomas of the gut. You can get melanoma retinopathy. Ocular motility and multifocal myoclonus, you see that in children with neuroblastoma. Anti-RI is associated with breast or gynecological cancers. We can take a look at paraneoplastic syndrome with anti-WHO antibodies associated with breast cancer and other solid tumors, with Hodgkin's lymphoma and non-Hodgkin's lymphoma, and they may have multi-factor or multifocal motor weakness. It stands to reason that the entire body can be affected by cancer if it metastasizes. So I think what we're trying to see here is that when we have metastasis, depending on the organ that's metastasized, um, where it metastasizes to, if the spread is too invasive, we're going to get not only movement disorder at the neuromuscular junction, we are going to get other neurological disorders. We'll get eye, sensation, feeling, movement, skin disorders, GI disorders, and we saw that small cell lung cancer is very aggressive in producing a lot of these, whereas your squamous cell is basically only famous for producing the parathyroid releasing protein. But small cell just does everything. So you have a smoker that comes in and he exhibits, symptom of inappropriate antidiuretic hormone, amongst other things, other paraneoplastic syndromes. You first on the differential diagnosis could definitely, or part of your differential diagnoses of all 10 could be small cell lung cancer, particularly if they're a smoker. So I want to thank you. This is a little bit in depth, something to think about. Don't get caught up in signs and symptoms. Hopefully everybody's fine. It's just something to think about when people start, not feeling good. Maybe some of the paraneoplastic syndromes are like the first signs to say, hey, something's wrong. And we need to recognize that. So thank you.